Hello, everyone, and welcome. You are listening to the Psychopharmacology Institute podcast. I'm your host, Dr. Wagdan Rashad. I'm here every 2 weeks to explore clinically relevant topics in psychiatry in general and psychopharm in particular. So today, we talk repurposing. What's that mean? It means using medications we have known for ages. Ones we use for things like gout and hypertension, and use them for conditions like depression. You know, it's like when you reuse your egg cartons to store your precious jewelry. Am I right? No? Okay, scratch that. One of the cases I had read was about a 61-year-old man who was diagnosed with schizophrenia at age 20. During his most recent hospitalization for it, he developed a bed sore that was treated with minocycline. 2 weeks later, the bed sore healed and minocycline was stopped. Guess what? The patient's schizophrenia symptoms worsened. Minocycline was resumed, and within 3 days, the patient's schizophrenia symptoms improved. That made the clinicians think, antibiotics for psychosis? How curious. Today, we have Dr. Jim Phelps covering new antidepressants that have been investigated for MDD. You'll enjoy this. In the reference section of this transcript, you'll find the citation of the paper so you can sink your teeth right into it. Dr. Phelps hosts our new CME podcast that we have called Quick Takes. He is a wizard at making psych literature digestible and easy to apply. If you're keen to stay up to date on the literature but don't quite have the time to read publications, Quick Takes could be perfect for you. Check out piupdates.com to sign up on our website, earn CMEs, and receive regular psychopharm nuggets of joy. Okay, I'll leave you with Dr. Phelps.
New antidepressants? That would be of interest to most of us. Well, here's a paper from Denmark that looks at new antidepressants that aren't even antidepressants. This is fascinating. And I particularly admire the principal investigator here, Lars Kessing, because he's done this before. He and his team just come up with a question and then turn to the Danish medical registry. The entire country, all the population is there in this medical registry, so they can ask epidemiologic questions very directly, relatively easily compared to epidemiologic studies in the United States, for example. And here they've done it again. And interestingly, the question was, are there things that people might take that lower the likelihood they will develop major depression? And there were some tantalizing things that Kessing and his team had recognized might have this property, so they studied it by looking at the National Registry. Just so you stay with me on this remarkable tour, all of the medications I'm going to name were associated with a lower risk of getting depression, and they are allopurinol, aspirin, angiotensin agents, things that affect the mechanism of action of angiotensin, and non-steroidal anti-inflammatories. All of them were associated with a lower risk of developing depression. Again, we're looking at this in this distant statistical fashion. But what they found is that sure enough, people who were taking these medications did not get a new diagnosis of depression as often as those who weren't taking such medications. Now, the problem with an approach like this has been called confounding by indication. Maybe people who take things like low-dose aspirin are just more health conscious, so they're healthier and less vulnerable to depression. Or maybe if they're conscientious about managing their gout proactively, you could see an implication that allopurinol lowered the risk of developing depression when really what you're looking at is someone who's conscientious about managing their health. To avoid this risk, Kessing and colleagues gathered data on periods of time when the same people were not taking these medications. So the outcome of interest was incident depression, new cases after the study medications. That would be allopurinol, aspirin, non-steroidals, and angiotensin agents. After those medications were instituted. And sure enough, the rate then in that phase for those patients was lower than in the general population. So the point is, Kessing and colleagues are using an available database to just explore a hypothesis. It's a way to get some insight here without having to mount a randomized trial. It's pointing our attention toward things that had already been examined in case control work, or there was some indication that is worth looking at. What we have then, in summary, is striking results that raise interesting questions. A purine pathway in depression, some sort of connection between angiotensin enzyme polymorphisms that had previously been examined, and serotonin, dopamine transmission. Sure enough, that is supported by this study. And then more support for anti-inflammatories as potentially having antidepressant properties.
Thanks, Dr. Phelps. I hope you enjoyed that, folks. So on the topic of new antidepressants, and in particular angiotensin, I have in my hand here a paper that has just been published on October the 16th, 2019 in JAMA by a prominent group from Ontario, Canada, that found, wait for it, angiotensin receptor blockers are associated with an increased risk of suicide compared to ACE inhibitors. This was a case control study of residents of Ontario who were aged 66 years or older. Now, I raised both my eyebrows when I read the title. However, did they come up with this correlation, I wonder? And will this impact the decision physicians might take when prescribing antihypertensives? I quote Dr. Mohammed Mamdani, who was one of the authors talking to Medscape Medical News, quote, "We looked into the possible mechanisms for this observation and found that angiotensin receptor blockers may increase angiotensin II levels in the brain more than ACE inhibitors. And patients with a gene polymorphism producing higher levels of angiotensin II in the brain were more likely to have mood disorders. So we wanted to investigate this further." I recommend you check out the paper in the reference section. I'd like to add that this paper has received a bit of pushback from cardiovascular clinicians who stated that confounding by indication and the evidence is not solid enough to alter practice. I think this paper will spark further research down the road, which will be interesting to see. And that's about me for today. I hope you liked today's podcast, and I'm glad I got to share with you some of the very recent findings so we can really impress your colleagues by the water cooler, eh? Next episode, we will continue our quest with MAO inhibitors, and I will see you then. Want to listen to more quick takes? Visit piupdates.com and become a premium member already. We have a bunch of CMEs for you to collect. If you are a psychiatrist in the US, we also offer SA credits. You can also go to our website and join our newsletter to receive weekly updates delivered straight to your inbox. The following people participated in this episode: Dr. Flavio Guzman as a general editor, Andy Rode as the audio engineer, Pamela Gonzalez as the project manager, and myself, Dr. Wegda and Rashad as the host. We'd also like to thank Dr. Jim Phelps for being with us. Thank you for joining us in today's podcast. Until the next episode, goodbye.